Innovation is anything which is new, in a sense. To quote Arthur Kornberg, the Nobel Prize winner, the future is invented, not predicted. Sometimes innovation can be very simple. And I personally am of a philosophy that the simpler a potential solution is, usually the more applicable and the better. In the world today, I would estimate somewhere between 15 and 20% of all women alive today are infected with papillomavirus. Current vaccines only cover 2 out of 14 high-risk papillomavirus types. They are the 2 main types that cause cervical cancer. Now, the vaccines, or current vaccines, are prophylactic. In other words, they are preventatives. They don't work, or they don't work very well if they're given to women that are already infected with the virus. So what it means is we have millions of women alive in the world today who will be at risk of developing cervical cancer for at least the next 20 to 30 years. Although cervical cancer is actually declining in the developed world, what is not widely known in developing countries such as Sub-Saharan Africa, India, South America, it is still the #1 cancer killer of women. These countries don't have the cervical smear testing that we have in Europe and the developed world, and even if they did, they don't have the surgical services that are needed to treat the disease when it's detected. So we tried, or decided to try and develop a treatment for early stage cervical cancer that would eliminate the virus and also the disease it causes. The innovation, very simply, is a new use for an old drug. There are lots of reasons why this is a good thing to do, because usually it's quicker to actually get the drug to the new use than developing a drug from scratch. Also, all the previous testing has already been done, so this is actually quite a good thing to do. The actual discovery was based on some molecular studies that we were doing in the lab looking at the function of the papillomavirus, and we came up with an idea that a drug which is normally used as a treatment for HIV, human immunodeficiency virus, might work as an antivirus against the papillomavirus and subsequent cervical disease that this virus causes. Now, the drug is normally given orally as a tablet or a capsule, but we found that the concentration that you needed to get at the cervix to work against the papillomavirus was probably about 10 times higher than one can get from oral administration of the drug. We needed to apply the drug locally to the cervix as a pessary. Now that traditionally would require reformulation of the oral form of the drug. Reformulation is not cheap. It costs a great deal of money. And the problem was no one would fund that reformulation without clinical data. In other words, did it work in people? But you can't get that clinical data without the reformulation. So you see the point, we were in a vicious circle. We were in a catch-22 position. We couldn't get one without the other. This whole process that we went through to get this clinical trial up and rolling, it could have fallen over at so many places, and it really was a wing and a prayer. I nearly gave up so many times. We tried to do it in the UK. For various reasons, there's no way. We couldn't get the drug, we couldn't get the formulation, the costs and all the rest. It just wasn't going to happen. Through discussions with a clinical PhD student of mine from the University of Nairobi, we realised that this drug was actually formulated in something that resembles a cod liver oil capsule. And we thought to ourselves, a bit naively possibly, but we thought this might melt very nicely in the vagina and act as a pessary without reformulating. We started off at the maximum dose that we had approved by Kenyatta National Hospital, which was 1 capsule twice a day. And the idea was, if we saw any adverse reactions, the dose would be reduced. But we didn't. A phase 1 trial is primarily designed to assess the tolerability of a treatment, whether there are any side effects, and we didn't see any. But what it doesn't usually produce, or you are very lucky if it does, is what's called an efficacy or efficacy output. And in our case, a very high proportion of ladies went back to having normal cervical smears, and subsequent biopsies were taken which confirmed this diagnosis. So it was actually quite a lot above our expectations. We want to take this to a phase 3 trial. We want to establish this treatment and make it such that it becomes the accepted clinical practice. Because if it works, it could save the lives of, well, hundreds of thousands of women. It's that simple. How could the Saatchi Bill help? Well, most ideas, concepts, most innovations don't work. You come up with an idea, you come up with a theory, you test it. If you're lucky, it pans out. So getting results from the laboratory to the clinic, anything which enables that, speeds it up, makes it easier, anything that facilitates that process to enable, if you like, greater patient choice, of course, informed choice with the right safeguards in place, that is important. I would never say it wasn't. But anything that smooths that process, makes it more available, I think has got to be a good thing.